Hi everyone, this is Carrie Fox coming to you from Lakeview Health. We will get started in approximately 4 minutes. Please hold. A bit about Lakeview Health in case you don't really know about us. Today we're coming to you from our Jacksonville campus. We're located in Northeast Florida, and we're a dual diagnosis addiction treatment center. We have this location, and then we also have an outpatient location in the Woodlands, Texas, which is just north of Houston. So in Jacksonville, we have gender responsive facility, which means that men and women are working on recovery in separate facilities and using curriculum and programs that are designed for each gender's unique needs. We offer a continuum of care from medically monitored detox all the way through intensive outpatient programs. And our board certified physicians partner with our licensed master's level clinicians to develop comprehensive individualized treatment programs to help people set a new course in health and in recovery. Lakeview is licensed by the Joint Commission, is licensed by each respective state as well as accredited by the Joint Commission. And then we're also members of NACAP and NABH. A little bit of housekeeping. We do welcome questions as we go along in the webinar. If you have questions, please put them in the question box that is located on the right side of the panel for your webinar. And we'll get to those probably toward the end of the webinar. We'll let Dr. Kaplan get through all of the material, and then we'll get to the questions. So please type those in as we're going, and we will address them. Common question, will the PowerPoint be provided? Yes, it will be provided. We'll send it in a follow-up email to you, and we'll get that into your inbox within the next 24 to 48 hours. We do appreciate feedback, so you will get a follow-up email that has both the post-test and the webinar evaluation. If you can complete those for us, we'd really appreciate it. We want to know what you think about this webinar, and if you have any ideas for webinars going into 2019, I'd love to hear what you would be interested in knowing about from Lakeview Health. And then our webinar series, this is the last one for 2018, but we will be back with the entire Lakeview webinar series next February, so watch your inboxes for that. Okay, moving on to the main event here. Dr. Kaplan is with us. He is our Corporate Chief Medical Officer. He has over 30 years of experience in psychiatry and forensic psychiatry. He graduated from the University of Miami School of Medicine and completed his postgraduate education at the University of South Florida. He continues his affiliation with the University of South Florida, serving as an associate professor with the Department of Psychiatry. And Dr. Kaplan is board certified by the American College of Forensic Examiners, the American Board of Forensic Medicine, and American Board of Disability Analysts. So I'm going to switch seats with Dr. Kaplan right now, and then he'll take you on through his presentation. Thank you.
Well, thanks, Carrie. I appreciate that. And welcome, everyone. Thank you so much for taking time out of your schedules to participate in this webinar on what I think is a really interesting topic, and that's for our patients who have addictive disorders. These days we use the word use disorders. Do they have comorbid or co-occurring psychiatric disorders, and how important is it to recognize, diagnose, and treat these co-occurring disorders? And I hope what you get out of the seminar is that this is really a very common problem for our patients with addictions, and if you don't diagnose and if you don't treat aggressively these disorders, quite simply, the patients have a really high risk of relapse. So it's really, really an important issue, and I hope you enjoy this webinar. So if you're looking at the presentation outline, we're going to talk about the epidemiology of this phenomenon, what types of patients have what types of co-occurring psychiatric disorders, how common are they, are there specific groups that we need to look at in terms of this phenomenon. And then we're going to look at the most common co-occurring psychiatric disorders found in patients with addictions. We'll look at the different diagnoses using the DSM-5 nomenclature. We'll look at treatment, recommended pharmacotherapies, or what we call somatic therapies, and various psychotherapies. And finally, we'll look at the use of MAT, or medication-assisted treatment, in these people with co-occurring psychiatric disorders. So a little bit about epidemiology. So in terms of nomenclature, when a person has a substance use disorder, and at the same time they have a co-occurring mental disorder, we use the term now co-occurring disorder. So in the past, the terminology dual diagnosis was used, and you can still use that term, but generally in the literature, we refer to this phenomenon as co-occurring disorders. So you can have co-occurring psychiatric disorders, and you can have co-occurring medical disorders. And the focus of today's webinar is not on co-occurring medical disorders, but just to kind of fill you in, the common person with an addictive disorder will have over time a co-occurring medical disorder. Patients with addictions have a much higher risk of cardiovascular disease, autoimmune diseases, respiratory diseases, cancers, things like that. So when it occurs at the same time, we refer to that as a co-occurring disorder. If you look at a 2012 national survey on drug use and health, it just shows the huge numbers of people in the United States and honestly all over the world who have these co-occurring mental disorders with an addictive disorder. So in the 2012 survey, 8.4 million adults in the United States had a co-occurring disorder. They had depression, they had PTSD, they had generalized anxiety disorder. At the same time, they had an opioid use disorder, or alcohol use disorder, cocaine use disorder. So the numbers are huge, and that's old data, so the numbers are bigger now. Okay, so probably somewhere in the 10 to 12 million Americans will have co-occurring disorders. So there are primary and there are secondary co-occurring disorders. So primary means you have a person who first develops a psychiatric disorder. They first develop major depressive disorder or generalized anxiety disorder. And then over time, they develop a co-occurring addiction disorder. Sometimes we use the term self-medication to describe what happens in these patients. So typical patient, person with generalized anxiety disorder. They wake up anxious, they're anxious all day long, they have trouble sleeping. What kind of substances do you think they're gonna use to self-medicate, to help themselves feel better? It's usually a relaxing sedative type of drug. So it's alcohol, it's a benzodiazepine like Xanax or Klonopin or Ativan or Valium, it's a barbiturate like phenobarbital. They self-medicate to provide some anti-anxiety relief to help reduce their anxiety disorder. And then what happens is over time, they do this so often that then they develop both a physiologic and psychologic dependence or addiction on these substances. That's called a primary co-occurring disorder. What's a secondary co-occurring disorder? Secondary means you first have an addiction. You first have alcohol use disorder or cocaine use disorder or opioid use disorder. And as a consequence of the effects of that drug on the brain, they then develop a psychiatric disorder. They develop depression, they develop anxiety, they develop psychosis, they develop a cognitive disorder as a direct consequence to the drug they are using. That's called the secondary co-occurring disorder. So what are some of the consequences of co-occurring psychiatric disorder? And this is a really important slide I really want you to focus on, because there are terrible consequences to this. And what happens in clinical practice, unfortunately, more often than we would like, is co-occurring psychiatric disorders are either poorly diagnosed or misdiagnosed, or honestly just neglected. And the focus is on treatment of the addiction, which of course is super important. But what we're going to see is there are serious consequences if you miss the diagnosis. Consequences in terms of adequacy of treatment, higher risk of relapse, things like that. So let's look at some of those consequences. So number one, reduced rate of sobriety. So quite simply, if you don't treat the co-occurring psychiatric disorder, the percentage of your patients, even if they're receiving good or adequate addiction therapy, the percentage of people that are sober, i.e. not using the substance anymore, is much less than if you treat the co-occurring disorder. Increased rate of relapse. So it's not just about getting people sober, it's keeping people sober. And we know with various substance use disorders, unfortunately, there's a pretty high risk of relapse. So one of the things that we try to do here at Lakeview and at other places is, what can you do not just to get people to be sober, but to keep them sober on a prolonged period of time. None of us want someone to have to come back into residential treatment or IOP or PHP 3, 4, 5 times. That's not what it's about. It's about getting excellent treatment, becoming sober, and then, if at all possible, staying sober, hopefully with no relapses, or keeping the percentage of relapse down to a minimum. If you don't treat the co-occurring psychiatric disorder, there's a much, much higher risk of relapse. Reduce compliance with treatment. So think about your depressed person, right? Lack of motivation, lack of drive, lack of interest. They're tired. They're inattentive, all as a consequence of their depression. Do you think that person's going to cooperate with their treatment for their substance use disorder? I mean, they may try, but it's a lot harder. Okay, so there's less compliance. There's less compliance with the various therapies that people participate when they're trying to overcome their addiction. If you treat the co-occurring disorder, now you have a person who feels better, who cognitively is more attentive, more motivated to participate in treatment, and then they get a lot more out of the addiction treatment. Increased medical co-occurring disorders. We kind of touched on this a little bit before. So if you don't treat the co-occurring psychiatric disorder, that person has a higher risk of the co-occurring medical disorder, right? So if a person has depression or generalized anxiety and you don't treat that person, even if you treat the addiction, is going to have a higher risk of having a heart attack or a stroke or some kind of autoimmune disorder. It's important for multiple reasons, including their physical health, to treat the co-occurring psychiatric disorder. Increased risk of suicide. So unfortunately, people with substance use disorders have a really high risk of suicidal ideation and, unfortunately, suicide attempts, and sometimes they are successful and they actually wind up killing themselves. So a serious, serious problem in the addiction population, and also with people that have co-occurring psychiatric disorders. 50% of people with major depressive disorder have thoughts of committing suicide. If you treat the co-occurring psychiatric disorder, you can drastically reduce the risk of suicidal thoughts and suicidal behaviors. And finally, reduce functionality. Quite simply, if you have a co-occurring psychiatric disorder and at the same time have a substance use disorder, you are less functional. You're less functional in your interpersonal relationships. You're less functional at work. You're less functional if you're going to school, focusing in class, learning your materials, getting good grades, things like that. So to improve quality of life, improve functionality, the psychiatric disorder that happens at the same time a person has an addiction must be evaluated and must be treated. So as you can see, when we ignore this or we're not evaluating sufficiently the risk of a co-occurring psychiatric disorder, there are a lot of really, really bad consequences. So this is a pretty famous study, a collaborative psychiatric epidemiologic study that looked at different factors among people with these co-occurring disorders. So we're looking at psychiatric and we're looking at addiction disorders. And to kind of separate cultures, Caucasians have the highest risk of a co-occurring disorder. So in this study, 8.2%, this is the general population, okay? We're not just looking at people who have addictions. In the general population, 8.2% of Caucasian people had, at the same time, a DSM psychiatric disorder and a DSM substance use disorder. 5.4% of Afro-Americans had co-occurring disorders, very similar to the Hispanic population, 5.8%, and the lowest percentage were Asian, people of Asian descent, 2.1%. Now, what comes first? Does the psychiatric disorder come before the addiction disorder or vice versa? And a lot of the thoughts in the past were actually, well, yeah, they're depressed because they've been abusing alcohol or they've been abusing opiates, and of course you're going to develop a depression when you use these kind of substances. Here's the danger in that way of thinking. So if you don't treat the co-occurring psychiatric disorder, a lot of patients are just not going to get better, even if they're sober. And we've talked about all the potential negative consequences of not treating. So having some knowledge about what comes first, the so-called chicken or the egg, is really important. Well, now we have some data, and it looks like the egg comes before the chicken. So in this study, the majority of people that had co-occurring disorders reported symptoms of the mental disorder before they developed symptoms of a substance use disorder. So in the majority of cases, you first have your psychiatric disorder, and then people develop a substance use disorder, sometimes as a consequence of this self-medication phenomenon. Gender issues, interestingly, really no data on this. So gender issues don't seem to be relevant in regards to an increased or decreased risk of co-occurring disorders. And the same thing for socioeconomic issues, not a lot of data. Let me just touch on the gender issues for a second. So there's not an increased risk of co-occurring disorders in men versus women. But if you look at psychiatric disorders, there's really significant differences. For example, depressive disorders. People with major depressive disorder, for every one male, there's two females with major depressive disorders. There's a 2-to-1 split, probably related to genetics and hormonal differences between men and women. Same thing for anxiety. For every one male with an anxiety disorder, 2 females will have an anxiety disorder. Again, probably related to hormonal changes and also genetics. In regards to bipolar disorder, it's a 1-to-1 split. There's no differences in the sexes. And in regards to attention deficit disorder, we see the opposite. So for every 2 men who have ADD or ADHD, 1 female will have the disorder. For antisocial personality disorder, men are the, I guess, winners, but they're really the losers. So more men have antisocial personality disorder than women. So let's look at some of the more common co-occurring disorders. And I know a lot of you that are watching and participating today have some type of experience with mental health disorders and addiction. So really none of this is going to surprise you. And these slides are the DSM criteria. If some of you are not familiar, DSM stands for the Diagnostic and Statistic Manual. We're in our 5th edition. So this is the book that mental health professionals use, and sometimes attorneys in forensic cases, that have the specific criteria to say this person fulfills the criteria for alcohol use disorder, or opioid use disorder, or stimulant use disorder, or major depressive disorder. These are the criteria that are necessary to diagnose a person. So first we're looking at major depressive disorder. Really, really common in people that have co-occurring psychiatric and substance use disorders. Here at Lakeview, I'm going to show you some of the psychometric testing that we utilize to evaluate our patients, but just to kind of give you a flavor, we're just starting to pull out some of our data. And our data is pretty consistent with the published data out there in the peer-reviewed literature, and maybe even a little more common. So what we're seeing is in our residents here, people that come to Lakeview, approximately 25 to 30% of our admissions will have a major depressive disorder, really, really common. So what are the DSM criteria? You need 5 or more of the symptoms documented there. And the symptoms have to occur for at least 2 weeks. And honestly, by the time we see people, and you in your practices, if you're a clinician, the vast majority of people have had these symptoms for literally months, sometimes years, sometimes their whole life. But it has to be at least a 2-week period of time. And you need at least 1 or 2 of the following symptoms. So dysphoria or depressed mood, and loss of interest in activities or pleasure. We call that anhedonia. So anhedonia is a lack of a pleasure from activities that in the past a person would have enjoyed. And then you need at least let's see, so you would need at least 3 or 4 of the other following symptoms in this 2-week period of time. So you have your mood, right, dysphoric mood, you have your change in interest, changes in appetite, usually decreased appetite followed by weight loss, but sometimes increased appetite followed by weight gain. Insomnia, more common than hypersomnia. There's 3 types of insomnia that occur in major depressive disorder. Initial insomnia, problems getting to sleep. Middle insomnia, problems staying asleep. And terminal or early morning awakening, waking up early and can't get back to sleep. But some people have hypersomnia, they sleep too many hours. Psychomotor agitation or retardation. Psychomotor retardation is kind of what you think of if you're going to think in your mind, what does a depressed person look like? They talk slow, they move slow. But remember, a lot of people with major depressive disorder have anxiety symptoms. So they're more agitated, they pace, they're restless. That's called psychomotor agitation. They're tired, fatigue, loss of energy. They feel terrible about themselves, excessive guilt. They feel worthless. They think they're ugly or stupid, very kind of low self-esteem when people have major depressive disorder. Cognitive symptoms, very, very common. Problems focusing and concentrating. And when you don't focus, you don't remember. So a lot of people with depression have memory recall problems. It's not like a dementia. It's not a memory disturbance. It's a disturbance of attention. And if you don't focus, you're not going to remember. And again, 50% of our patients with major depressive disorder have thoughts of committing suicide. 15% are going to have some kind of suicidal behavior, right? So these are the symptoms of major depression. So just like think about these symptoms, you know, if you feel bad about yourself and you're tired and you're not focused and you're thinking about killing yourself and you didn't sleep, how hard is it going to be to go to your 12-step meetings and to go to your individual counseling and to work on your sobriety? It really makes it tougher, right? So we can diagnose and we can treat aggressively this co-occurring disorder. People are going to be so much better able to work really hard in their addiction treatment. Super important. GAD, generalized anxiety disorder. So believe it or not, GAD is the most common psychiatric disorder that there is. A lot of people think depressive disorders are more common, but if you look at the epidemiologic data, GAD is more common in the United States than major depressive disorder. Lots of people are anxious. So what are the criteria, the DSM-5 criteria for generalized anxiety disorder? There's excessive anxiety, too much, worry, they're apprehensive, and this occurs most of the time for at least 6 months or more. And it usually worsens with various psychosocial things going on, school, relationships, work performance, things like that. And the person finds it hard to control the amount of worry that they have. The anxiety and worry are associated with at least 3 of the following 6 symptoms, and these being restlessness, the person paces, they're on edge all the time, they're exhausted. Just think about it. If you're anxious all the time, all the energy you're using, people are exhausted. They have problems focusing, their mind goes blank, they're irritable, pissed off, bothered, easily annoyed. They get a lot of muscle tension. So there's a lot of people with GAD that have a lot of co-occurring medical complaints, right? So think about it. If your muscles are tense all the time, what are you going to do? What's going to happen? You get headaches. You're going to get body aches. You're going to get chronic back pain, things like that. And they have insomnia, sleep disturbance, problems falling asleep, initial insomnia, problems staying asleep, middle insomnia, or just this kind of description of a non-restorative, a non-satisfying sleep, all right? So GAD, really, really common as a co-occurring psych disorder related to an addiction disorder. Bipolar disorder. So we talked about major depressive disorder. So for those of you not familiar, bipolar disorder, sometimes referred to as manic depressive disorder, is a disorder in which you can have a full-blown depression, but at least once during your life you've had at least one manic or hypomanic episode. So if someone had a hypomanic episode and they flip into depression and they never get full-blown manic, we call that bipolar type 2. If someone has a full-blown mania into depression, we call that bipolar type 1. So if you ever see documentation, bipolar type 1, bipolar type 2, that's what we're talking about. So these are the criteria for a manic episode. You already saw the criteria for a depressive episode. So during this period of the mood disturbance, mania, energy goes, think of the opposite of depression, right? So energy goes up, and they're involved in more activities, okay? They have inflated self-esteem or grandiosity. So someone who doesn't normally think excessively wonderful about themselves, now they think they're the smartest and they're the most attractive person. And they get these grandiose ideas. Sometimes it gets delusional. I'm Jesus Christ, I'm head of the mafia, I'm president of the United States, right? So they get so grandiose that it gets delusional. They have false beliefs. That's a psychotic bipolar disorder. Because you have so much energy, you don't have to sleep. So we don't really call this insomnia, we call it a decreased need for sleep. You don't want to sleep. In depression, you're exhausted. You want to sleep, but you can't. In mania, you have so much energy, you don't need to sleep. So people sometimes don't sleep at all. They sleep 1 or 2 or 3 hours. They're more talkative than normal. There's a pressure of the speech. And you want to compare it to their normal pattern. If normally people have a kind of normal pattern of speech, now there's this excessive, fast, pressured speech. Sometimes they speak so fast you can't even keep up with them. Flight of ideas, multiple thoughts going on in their brain all at the same time. Distractibility, there's so much going on in their brain, they're thinking of so many projects they can't focus attention. Increase in goal-directed activity. So normally, a person has a kind of interest in certain things. When people get manic, they have an increase in interest in things maybe they never were interested in the past. They start new jobs and they start new projects and they become more social, they become more sexually active when it's inconsistent with their normal sexual behavior. They spend more money, right? So excessive involvement in activities that have a high potential for painful consequences. In other words, you're making really bad judgments. When you're manic, you're buying cars you never would have bought, and you're participating in sexual behaviors you never would have thought about in the past, right? So this is a manic episode. So when someone has bipolar disorder, they like the feeling often. They crave this, and they'll use substances to self-medicate. So what might they use? Well, if you want to use something to keep the mania going, you can use a stimulant, perhaps like cocaine or methamphetamine. And then if you want to sleep but you can't sleep, you're going to use a sedative of medication, a benzodiazepine, a Xanax, a Klonopin, a Valium, a phenobarbital, things like that. So we see different drugs used during manic episodes. ADHD, the next, I think, 2 slides, let's see, I'm going to go back now. So the next 2 slides for ADHD, I could spend an hour talking about this. So we're going to make this slide available to you if you want to kind of come back and take a look at them. But quite simply, there are a variety of potential symptoms that can fulfill the DSM-5 criteria for ADHD, and you have inattention symptoms, so ADD, and then you have the potential for hyperactivity symptoms, ADHD. So this is a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning. And people who have ADD or ADHD first develop the symptoms during childhood. And you might have heard of adult ADHD. Well, people really don't develop ADHD as adults. They were just never diagnosed in the past. So if you look at the epidemiologic literature, people first develop ADD, ADHD as a child, and then it continues during their lifespan. About 45% of people, the symptoms just go away, and as adults, people don't have ADD, ADHD. And about 55% of people, the symptoms remain as adults. So they may never have been diagnosed during childhood, but the symptoms began during childhood. So here's some of the inattention symptoms. Failure to give close attention to details, making a lot of careless mistakes at school or at work. Problems focusing attention at tasks that really you have to focus attention, like studying for a test. Problems organizing things. Dislikes tasks that require attention. So you'll see a person in adulthood never completed school or never chose to look for jobs that they really might have enjoyed, but because a lot of attention was necessary, they chose different kind of jobs, and they often are not as successful as they could have been because they stay away from these kind of jobs. Forgetful in daily activities, forgetting homework, forgetting work projects, things like that. Hyperactivity or impulsivity, fidgeting, leaving class early when they're supposed to be sitting in their chair, not able to play or engage in quiet leisure activities, on the go, blurting out answers, problems awaiting turn. A lot of times, children with ADHD present not because of the inattention symptoms. Those kids actually sometimes get lost because they don't cause any problems. It's the hyperactive kids that are breaking things, touching things, causing havoc. They get the attention, right? So ADHD as a comorbid or co-occurring psychiatric disorder, often people self-medicate with substances to improve attention, right? So cocaine and psychostimulant meds work in a very similar way. They both increase dopamine and norepinephrine. So if a person has ADHD and they use cocaine, they'll often say things like, I never felt this normal. I can focus attention because they're hitting the same neurotransmitters. So we see a lot of development of cocaine use disorder, psychostimulant use disorder, Ritalin, Adderall, things like that in people with ADHD. And psychotic disorders. So psychosis is when their thoughts, their behaviors are out of touch with reality. You can have hallucinations. You can see things, visual, hear things, auditory, smell things, olfactory, feel things, tactile, that are not there, or delusions. Delusions are false beliefs, right? So you can have paranoid delusions, thinking that people are trying to kill you, grandiose delusions like in mania, people that think they have special powers that they normally don't think that they have. These are delusional symptoms. So these are psychotic disorders that can occur at the same time that there is a substance use disorder. And these are the kind of four most common kind of psychotic disorders. So you can have psychosis related to actually the drug, right? So amphetamines can produce psychosis, cocaine can produce psychosis, excessive opioids can produce psychosis, excessive alcohol, and cannabis, marijuana. You know, in our society now where marijuana use is legal in some states and medical marijuana in a lot of states, a lot of people look at cannabis as a benign substance, but people can become psychotic from the THC in cannabis. From withdrawal from psychosis, from certain substances, you can develop psychosis. Delirium tremens is severe withdrawal from alcohol. That's why we have to bring people into a residential facility like we have here and detoxify them, because DTs can produce psychosis, but also, unfortunately, it is deadly. About 15% of people with DTs die from the severe withdrawal, the hypertension, the seizures. So people have to be appropriately detoxified. Part of DTs can be something called formication, feeling ants and spiders crawling all over your body. So that's from withdrawal. Schizophrenia, a chronic psychotic disorder. We have a big problem with people with schizophrenia using and becoming addicted to various substances. Bipolar disorder, commonly we see psychotic features. And depression, 10 to 15% of people with depression have psychosis, right? So these are different disorders that occur, that have psychosis, that can co-occur with different substance use disorders. A little bit more about the prevalence of co-occurring mood and anxiety disorders. So this is a study that basically shows that if a person has a substance use disorder, if they have a mood disorder or an anxiety disorder, they have a 2 times increased risk, a 2-fold increased risk of having an addiction, right? So if you have depression, if you have anxiety, you have a much higher, significantly higher risk of developing addiction. A recent epidemiologic study suggests that as many as half of veterans who have post-traumatic stress disorder have a co-occurring substance use disorder. Commonly, we see this among our military who return from the battlefield. They develop PTSD and they self-medicate. We saw a lot of that in the Vietnam War. For bipolar disorder, the lifetime prevalence, so which means the chances that you have this during your lifetime of alcohol and cannabis use disorders, is 42 and 20%. So 42%, almost half of people with bipolar disorder, if you follow them during their life, they're going to have alcohol use disorder. 20% of people with bipolar disorder will have a cannabis use disorder. Really, really high percentages. So how best to diagnose people? First of all, people who have substance use disorders really should have a mental health proper evaluation. Psychologist, master's level person with experience, psychiatrist. Really important to have a thorough evaluation. And it's my strong suggestion that one of the things that should be part of that mental health evaluation is the use of psychometric tests. So what I'm showing you here is our profile at Lakeview Health that we utilize on all our patients. Day one, when they come into our facility, every patient fills out these various psychometric tests. These are short, self-administered tests. And the nice thing about these, so get the slides and Google these tests. They're free. You can just download them. The patients fill them out themselves. They're easy to score. And it does a couple of things. It assists you with diagnosis. And I know you all know this, those of you who are clinicians out there. Patients don't always tell us everything that's wrong, but they might answer things on a sheet that has questions, right? So it gives us the opportunity to look at certain symptoms that they describe in these tests, and then when we're doing our examinations, to ask them questions about it. So for major depressive disorder, the PHQ-9 is the most commonly used psychometric test to utilize that looks at various DSM-5 symptoms of depression, gives you a score, and then the other thing is you can follow people. So here at Lakeview, we follow people that are positive for the PHQ-9 to make sure our treatments are working and when they have a reduction in depressive symptoms. For bipolar disorder, the MDQ is commonly used, and what that does is it looks at episodes of manic symptoms. For generalized anxiety disorder, the JD-7 is the most common psychometric test utilized. For ADHD, at least in the adults, we use the adult ADHD scale. If you have children, the Connor scale is often used. And the Connor scale is kind of nice because one of them is used for the parents, and then you can give the scale to teachers to get additional data how our children are acting at school. And to follow people, we use a really simple scale called the Patient Global Improvement Scale, PGI. Look it up, download it, it's really easy. And what it does is the patient basically says, I'm no better, I'm worse, or I'm better. And it just gives you a snapshot to make sure your treatments are working. And if they're not, then you get together as a treatment team, you figure out what's not working so you can implement appropriate treatment. So how do we treat these co-occurring psychiatric disorders? First of all, treatment works. It really does. Both medications, appropriate medications, and psychotherapies work. So provide treatment to your patients with co-occurring disorders. They get better, you improve quality of life, you reduce risk of suicide, and you improve your addiction treatment. These people don't relapse as much. Treatment improves quality of life, no question about it. They are happier, they're more satisfied people. Treatment increases the rate of sobriety and reduces the risk of relapse. We talked about that. Treatment reduces medical co-occurring disorders. If you treat their depression, their anxiety, and at the same time treat their addiction, they're not going to have as many heart attacks, as many strokes. You lower the risk of cancer. You lower the risk of suicide. And treatment reduces the risk of suicide. Super important. So diagnose, treat, take it seriously, treat it aggressively. Secondary co-occurring disorders. So this is probably a slide that some of you might disagree with me on, and that's fine. It's always interesting to have conversations and different thoughts. So to treat or not to treat, that is the question. So here's what I mean by this. I think for a really long time, the belief was if a person first did not have depression, anxiety, things like that, right? They first have their addiction disorder, alcohol use disorder, opioid use disorder, and then they develop depression, generalized anxiety, what have you. We should wait. Let's just wait. Let's get them sober and let's wait and see what happens over time. And that's the way a lot of clinicians look at this. I have to say I don't necessarily agree, okay? I think you have to look at every patient individually. You got to look at their history to determine if you treat or not. I mean, it is true some people who have depression or anxiety as a consequence of certain substances, once they're sober, those symptoms will get better. But not always, not always. So here are some of the factors to consider when you as a clinician are making that decision. Number one, severity of symptoms. If I have a person with major depressive disorder and they're having trouble getting out of bed and they're seriously contemplating suicide, I'm going to treat that person more aggressively. I'm going to treat the depression while I'm giving them addiction treatment because of the terrible consequences of not treating that depression. If they have super mild depressive symptoms, no suicidal thoughts, they're fully functional, I might be less aggressive and give that person more time to see if the depressive symptoms lift. What are the impact of symptoms on treatment? Again, if that person is inattentive in group therapy and poorly motivated individual therapy, they're not going to get as much out of their addiction treatment than a person who's more focused, motivated, excited about treatment. So if the symptoms impact my addiction treatment in a negative way, I'm going to be more aggressive in treating that person earlier. And finally, do they have a past history of psychiatric disorders, including suicidal thoughts and severe functional negative impact of their symptoms in the past, right? So if someone had several episodes of depression, when they were depressed, they felt suicidal, they had trouble going to work and engaging in interpersonal relationships, I'm gonna look at that data to say, well, you know, we know they have a high risk of recurrent depression. I'm going to treat that depression while at the same time I'm giving them addiction treatment. To treat or not to treat, generally I'm going to say to treat. Here are some of the treatments. Somatic treatments just mean non-psychotherapy treatments that we use in co-occurring disorders. And I kind of bolded, do not use controlled substances, right? So I have to say a lot of clinicians don't follow through with that. I think that's a mistake. If you have a person with an addiction, my strong opinion is don't use medications that have addiction potential when you treat their co-occurring psychiatric disorder. I just think it's a good rule to live by so that we don't increase that person's risk of now abusing the treatment that we're giving them. So quickly, for major depressive disorder, we're going to use a wide variety of FDA-approved antidepressant medications to treat their depression completely, no addiction potential, and works well while they're receiving their addiction treatments. Electroconvulsive therapy, almost never used, but the point is, in some locations in the United States for severe suicidal depression, sometimes used. How about TMS? If you're not familiar, transcranial magnetic stimulation. This is a machine that has focused magnetic stimulation to areas of the brain, usually the left frontal area, which we think is the kind of the seed, the area that most biologic depression occurs. And through a series of treatment sessions that occur 5 days a week for about 6 weeks or so, the use of this magnetic stimulation produces antidepressant effects. Here at Lakeview, we have a TMS machine, and we utilize TMS as one of the possible treatments to help our patients with co-occurring major depressive disorder. So people that don't want to take medications, that is a treatment option. For bipolar disorder, quite simply, the rule is stay away from antidepressant medications, right? So if a person's bipolar and you're seeing them in a depressed phase, the knee-jerk response is put them on antidepressant. Big mistake. You can make someone psycho more and you put them on antidepressants. So the treatment for bipolar disorder in the manic or depressed phase are mood stabilizers like lithium, which we don't use that much these days, but you can still use it. Anti-seizure meds, which are anti-seizure mood stabilizers like lamotrigine, Lamictal, Depakote, valproic acid, Tegretol, carbamazepine, sometimes off-label Topamax or topiramate, and the atypical antipsychotic mood stabilizers, things like Zyprexa and Seroquel and Risperdal and Latuda and medications like that. How do we treat generalized anxiety disorder with medications? Antidepressants. I wish we called them something different because antidepressants are used for so many different disease states. So antidepressants are FDA approved in the treatment of generalized anxiety disorder. Usually the SS and the SNRIs, like Prozac, Zoloft, Paxil, Celexa, things like that, or Effexor, Cymbalta. And off-label, we use the anticonvulsants like gabapentin, which has some anti-anxiety effects in some patients. For ADHD, there are other meds to use other than Ritalin and Adderall and Vyvanse. Those are the psychostimulants. They have abuse potential. Strattera is an FDA-approved medication that raises norepinephrine, and it is FDA-approved for ADHD. How about Wellbutrin? Wellbutrin, this is an off-label use, but there's a lot of studies showing that Wellbutrin, which raises dopamine and norepinephrine, the same neurotransmitters that the psychostimulants like Ritalin and Adderall increase, Wellbutrin can be used off-label to treat ADD or ADHD, and it's non-addictive. And for psychotic disorders, quite simply, no matter what the cause is, we use antipsychotic medications. The traditional antipsychotics like Haldol and Mavane and Trilphon and meds like that, and the newer agents used more commonly, the Zyprexas and the Rispedols and the Seroquels and things like that. And let's not ignore psychotherapy. Psychotherapy is a very effective treatment to treat the co-occurring psychiatric disorders, as, of course, you're using psychotherapy to address, to educate, to treat the addiction disorders. So for major depressive disorder, the most commonly studied and used psychotherapy is cognitive behavioral psychotherapy. Physical exercise, when used on a frequent basis, is helpful. DBT is very helpful. It's a type of cognitive behavioral psychotherapy. For bipolar disorder, we use the same therapies during the depressive episode, but during the mania, it's more support, managing behavior, exercise, trying to use some meditative types of techniques. For generalized anxiety disorders or other anxiety disorders, cognitive behavioral therapy, recommended treatment of choice. For post-traumatic stress disorder and additional therapy, EMDR can be useful, meditation, physical exercise. For ADHD, learning a variety of behavioral strategies to help with organization, follow-through, things like that. And finally, just a little last slide on medication-assisted therapy. So when people think of MAT, if you're not familiar, MAT stands for medication-assisted treatment. This is when people with certain addictions, like opioid use disorder, will use some type of medication to reduce craving and to reduce the risk of relapse, like a Suboxone, buprenorphine, things like that. But medication-assisted treatment is really more than that. It's the use of any medication to do two things: reduce the risk of craving for the drug and improve sobriety, reduce the risk of relapse. So really, when you think about it, everything we talked about in the last half an hour or so, all the meds that we're using to treat the co-occurring psychiatric disorders is actually considered a type of medication-assisted treatment. But there's actually a specific medication that can reduce withdrawal symptoms and craving for certain drugs and that's and which is non-addictive, and that's Wellbutrin, bupropion. So bupropion can reduce withdrawal symptoms and craving for smoking, for tobacco issues. The past marketed under the name of Zyban. Zyban is bupropion or Wellbutrin. And for cocaine and amphetamines, although it's an off-label use of the medication, bupropion can reduce craving and reduce the risk of relapse in people that have cocaine and amphetamine or other stimulant use disorders. So in conclusion, we looked at this, I think, fascinating situation with a lot of our patients who have addiction disorders, in that they first, and sometimes second, have a co-occurring psychiatric disorder. We looked at how common this is, the epidemiology. We looked at the devastating consequences of these co-occurring disorders and the consequences of not diagnosing and treating it. So I hope if you got anything out of this webinar is that you understand how serious this is, and maybe it kind of stimulates your interest in evaluating your patients a little more thoroughly and making sure they get the appropriate treatment of these co-occurring disorders. And we looked at the more common DSM-5 diagnoses that occur commonly with addictions and how to treat them both with medications and appropriate psychotherapies, and a little bit about medication-assisted treatment. And I think it's time for some questions now.
Yeah.
Do we have any?
If you do have questions, please, again, in the right side panel of your webinar, there should be a questions panel that you see. Go ahead and enter your question there. We do have one here from Wendy. Is there any MAT for methamphetamine dependence?
So nothing that's FDA approved, but methamphetamine is a type of amphetamine. And the way amphetamines work, think of the psychostimulant Adderall or Dexedrine, which is dextroamphetamine. So all amphetamines work the same way. They very quickly and robustly raise dopamine and norepinephrine in the brain, especially in the hypothalamus area of the brain. Kind of, if you put a sewing needle in between your ears and between your eyes where they come together, that's an area of the brain really important in mood regulation, our drives, craving, appetite, sexual craving, things like that. So when you have this flood of dopamine and norepinephrine, what happens is there's a very high euphoric effect, but then you deplete your levels of dopamine and norepinephrine, and that's what we think causes the craving. When there's this lack of norepinephrine and dopamine, people crave the drug. We see the same thing with crack cocaine, and they have a high risk of suicide because then they get as high as they get that low and they get suicidal. So the use of bupropion, which raises dopamine and norepinephrine, would be a very reasonable MAT for people that have methamphetamine use disorder.
What is your experience at Lakeview regarding prevalence of patients struggling with co-occurring disorders?
So as I stated when I showed you the psychometric tests that we use here, we use psychometric tests for various purposes. Every patient here gets a psychiatric examination, and we use the test as data to pick up these symptoms, to diagnose people properly, to treat them, and then we follow them with these tests to make sure our treatments are effective. So we're just beginning to take our data and look at the phenomenon of co-occurring disorders. So what I'm going to give you now is not exactly accurate because we're just starting to pull out our data, but here are kind of some snapshots. So it looks like about 25% of our patients, when they get here, they have a co-occurring major depressive disorder. It looks like about 25 to 30% of people have a co-occurring anxiety disorder, mostly generalized anxiety disorder, some panic disorder. I'm blown away with our ADHD data. It's really high. It looks like somewhere in the 15 to 20% of people who come here have symptoms consistent with adult attention deficit disorder. So those are the three most common co-occurring disorders that we see here at Lakeview, and maybe if we do a similar seminar in the future, I'll have very specific data for you. But What's more exciting is not just our information that we're seeing about the prevalence, but now then we follow people, and it's pretty exciting. People are getting better. We have data showing that if you come here with depression, the depressive scores go down substantially. The anxiety scores go down substantially. The point I'm trying to make is use these scales, and in your practices, follow them. Use them again to make sure that the treatments are working, because it really makes a big difference.
How is co-occurring treatment written into the discharge or step-down plans in terms of outpatient care after residential PHP and IOP?
Great question. So what's the use of treating people if then you stop treatment when they leave a place like this, right? Or if they're in a intensive outpatient program or partial hospitalization program, and then we just stop treatment? I mean, that really makes no sense. And if you look at the data, quite simply, if you treat someone, even if they improve, and you stop your treatment, relapse rate is super high. It's like 80–90% within a calendar year. So there needs to be consistency with treatment. So, here's some recommendations, the things that we do here. So before people are discharged, we make arrangements and an appointment to continue the treatments for the co-occurring disorders, as well as, of course, the various treatments and programs for their addiction treatment. So, for example, if someone is benefiting from cognitive behavioral therapy, I'm going to want that person to have an appointment with a master's or PhD level therapist who has experience in cognitive behavioral therapy. If they're on an antidepressant medication or mood stabilizer, I'm going to want them to have an appointment with a clinician that has experience and training using these meds, a psychiatrist, a psychiatric nurse practitioner, a psychiatric physician assistant, a primary care doctor who has a lot of experience using these kind of medications. So the point is, it's important to have appropriate outpatient follow-up when they leave a place like Lakeview or any other place in the country, both for residential and PHP, IOP. Let me also talk about non-professional treatments, but treatments nonetheless that are really helpful, like meditative treatments and like exercise. I mean, all the data says the same thing, and my clinical experience is so consistent with this. People that are active physically, people that exercise on a routine basis, they have less risk of relapse. They are less anxious. They are less depressed. So whenever possible, and it's hard because it's really hard to get people to exercise consistently, but if you can get people to buy into this and to be more active physically, they just do better with whatever kind of treatments that you're providing them. So.
Great, thank you. Could you go into a little more detail about the effects of cannabis and youth, young adults living with ADHD?
Sure. So again, I struggle with the issue of cannabis in our society right now, because I kind of feel like an old fogey, so to speak, because I'm just really opposed to it. I have to tell you, and I'm opposed to it because of my, I got 30 years of clinical experience observing the effects and seeing what happens to our patients here at Lakeview who have become addicted to cannabis. So a couple of things. Number one, people that smoke cannabis on a routine basis often develop what we call amotivational syndrome. And what that syndrome is a kind of chronic influence of cannabis on that person's motivational level. They are just not motivated to do anything. They're not motivated for their school classes and their extracurricular activities. They stop sports and they stop clubs and they stop socializing. Except, of course, that socializing includes the use of cannabis. They stay in bed and they stay on YouTube and Netflix, etc. They lack drive. And it's such a waste. They will look back once they get sober and they stop using cannabis. They will look back on their high school years and be so upset and so disappointed that they wasted all these years where they could have accomplished more, had more loving and better friendships, been involved in sports and other activities. So I'm really opposed to the use of cannabis in our youth, even if they don't fulfill the criteria for cannabis use disorder, because of the negative impact it has on their life choices, on their motivation, on their ability, to achieve in their lives. The other thing is, remember THC, which is the chemical in cannabis that produces the psychoactive effects, is a fat-soluble chemical, okay? And when you think about it, the brain is mostly fat. Right? So if someone calls you a fathead, that's a compliment. You need fat. You need these omega-3 fatty acids for the brain to function well. So when someone smokes with any frequency, THC accumulates in the brain, and it does have a negative impact on cognition. People are less attentive. They're more distractible. They have problems with recall memory. They have problems with speed of thinking. They have problems with speed and accuracy of calculations and what we call working memory, that memory that we kind of keep in our minds to do something with it, to solve a problem, to plan something in the future. All these things occur in people that smoke with some kind of frequency. And we think that's the consequence of the accumulation of THC in the brain because of the fat-soluble chemical. So for all these reasons, my strong suggestion is that we do whatever we can do to reduce and limit the use of cannabis in all ages, but especially the adolescent population.
Last question. It is 1 o'clock, so we do appreciate everybody that was able to join us. If you're available to stay around for this last question, we appreciate it. I was recently introduced to neurofeedback therapy. Is that similar to TMS?
It is not. Neurofeedback is great. Neurofeedback utilizes various techniques, often computers, to assist in influencing the types of brain waves that a person has at any one time, which can lead to feelings of relaxation, reduction in stress, and things like that. TMS is very different. So TMS uses very high potency magnets. So almost think like an MRI machine, really, really high potency magnets. And through those magnets, I mean, there's specific machines that we use to provide the TMS treatment. It focuses these high magnetic forces to certain areas of the brain. So when someone gets TMS, you actually measure their skull and their brain, and you focus the magnetic stimulation to certain areas. And as a consequence of this, people get antidepressant effects. Now, the exact mechanism of action is hypothetical, but we think that the pulses of magnetism lead to the release of neurotransmitters similar to antidepressants that produce antidepressant effects. So people that receive these potent magnetic stimulation of certain areas of the brain will have increases in norepinephrine, serotonin, dopamine. The other thing is if you do PET scanning, positive emission tomography, where we get a picture of the metabolism of the brain at any one time, usually in depressed people, the left frontal lobe is cold. There's not a lot of metabolism. You give someone TMS, you see the increased metabolism in the left frontal lobe, which leads to antidepressant effects. So, certain types of biofeedback mechanisms are really good for people with different anxiety states. TMS, very different and primarily utilized for people with major depressive disorder, especially people that responded poorly to antidepressants in the past.
Thank you so much, Dr. Kaplan.
That's my pleasure. That was just fine. I hope people learned a little and enjoyed the presentation.
Thank you, everybody, for joining us today for the webinar. We'll have Dr. Kaplan back next year, I'm sure, for part of our series. Just a little bit of housekeeping. We'll send an email within the next hour with our post-test and evaluation. Please, again, fill those out so that we know if this was of interest to you and any other topics that you'd like to hear about in 2019. Otherwise, have a great day, and we'll see you back here next year.
Great. Happy Thanksgiving, everybody.